Okay, so here's Jupiter. Chilling. Damn, that's a sweet Jupiter, you might say. Wrong. Today we're going to be looking at the 2008 Jupiter trial, or the justification for the use of statins in primary prevention, an intervention trial evaluating rosuvastatin, presented by yours truly, Conan Liu, MD. And I think the program coordinators wanted us to include the journal citation, so this article was done by Dr. Ridker, and it was published in the New England Journal of Medicine. So, it's a big deal. It's a big, important topic here. And let's go over the PI and the C and O, or the PICA for short. So the P stands for population. So we were looking at patients with normal LDL, less than 130, and an elevated CRP of greater than 2. And their intervention was rosuvastatin 20 milligrams daily versus a control of placebo. And their outcome was looking at major cardiovascular events. So basically what this trial was conducted for was to see, can CRP be used as a marker for initiating primary prevention of cardiovascular disease? Because we know we want to start a statin in people who need secondary prevention. We want to start a statin in people with LDL of greater than 190, but what about in people with low to normal levels of LDL? Can we find a marker that could risk stratify the people who might have a cardiovascular event and then get them started on a statin early in order to prevent that event? But first, let's rewind a little bit. So how did I get here, and how I have two questions. So first of all is, how did I get into this position to be presenting to you guys today, and why did I choose this topic? And the second question, so that's the first question. And the second question is, what's the background and context for the Jupiter trial? So why did they decide to do this trial? So to answer the first question, why did I choose this topic and how did I get here? So I was in the ACC, our favorite place, obviously, chilling with our main man, Dr. Garcia. And this is just like a publicly available photo on Google. Apparently one of his patients just loved him so much. You could just find this online. So this is pretty cool. I was like making my YouTube vlog or whatever. And all of a sudden, Sunny and I got this email. You have each been assigned Journal Club on Friday. So all of a sudden, alarm bells were ringing. And we got this list of articles we could choose from. And I immediately was looking through them and thought, this one looks interesting. Statins in patients with elevated CRP. So why was I interested in this article? Well, as you know, Kwan and I have this roommate named David. And as I've told Santi before, during orientation, I said that David is a gem. He's a very unique person. The guy's super cool, and he eats like 5 sticks of butter every day and has a 6-pack, and he's super fit. He's really into nutrition, and he tells me all these like cool studies about nutrition, like how LDL-C and LDL-P are different, and we really should be using LDL-P as a better as a better marker for atherosclerotic risk compared to LDL-C. And actually, in medicine, everything we use is based on LDL-C. So it feels like we're really behind in terms of our understanding of lipidology and nutrition. Another thing, so again, this is going to be like going on a bit of a tangent, but this is a study that we're all going to become familiar with. But most of our understanding of nutrition and the dietary guidelines from the US are based off this horrific study, basically, called the 7 Countries Study. And it's cited all the time, so you'll see it all the time. But it's kind of an example of a really biased and kind of just manipulated study where they manipulated the data in order to prove what this doctor here, Dr. Ansel Keys, wanted to prove, which is that fat is bad. So on this graph here, you can see as you eat more fat calories, you have more degenerative heart disease. But one of the things that was later found out about this article was he really handpicked and cherry-picked the data. So he looked at countries that would prove his point that fat caused heart disease, but removed countries like France, who have an extremely high amount of saturated fat consumption and butter consumption, but they actually had much lower rates of cardiovascular disease compared to these countries here. So after this study was published, it really led to this kind of mantra that we had. Fat leads to cholesterol, cholesterol leads to heart disease, and heart disease leads to the dark side. And this led to the US dietary goals in 1977, which told us to increase carbohydrate intake, which I think from a current understanding of how carbs are for the body, I think people don't really kind of recognize that increasing carb intake doesn't really sound like the best idea. And because of the 7 country studies, they said to decrease fat intake. And this led to the publishing of the goals. And this is the rate of obesity in the US. And you can see when the dietary goals for Americans was published in 1977, all of a sudden, the rates of obesity skyrocketed. So I mean, obviously it's not causation, but there is a correlation here, and who knows if it's related. But one of the videos that I really liked this series on YouTube, Adam Ruins Everything. I don't know if some of you have seen it, but they talk about how low-fat foods are making you fatter. So basically, after the dietary guidelines were published, there was a big craze for eating low-fat foods. So all these manufacturers were starting to make low-fat foods, and the problem was that they tasted horrible because they had no fat in them. So what they did to make them more palatable was just add a crap ton of sugar into them. So now everybody started eating these low-fat foods, but they were just kind of pumped with a ton of sugar. And since then, we've had the skyrocketing rates of diabetes and obesity. So that's reason number one why I like this subject. And number two is I'm sure you guys are all dealing with inbox management. This was my inbox last night. It was at 0, and then all of a sudden I had like 15 different things to do. I was like, what the heck happened? Thankfully, a lot of them were duplicates, so I ended up being okay. But a lot of times, the patients that I've been seeing have cholesterol issues, or we're getting a lipid panel for one reason or another. And a lot of times I was like trying to figure out what I was supposed to do. So in this patient, for example, his LDL was 115, and previously it was 200 3 years ago. So that seems pretty good. He was on atorvastatin 80 milligrams daily. So that seems like a pretty good response, right? So he has a history of CAD and an NSTEMI about 6 years ago. So what do you think about his LDL? And I think this is one thing where, like in med school, I feel like I learned when to start a statin in somebody, but I didn't really learn like what do you do after you start in the statin on somebody. Like now that we got this result back, what am I supposed to do with this? The other thing is for this patient has not been on a statin. He's had an LDL of about 100 chronically. And like, what do I do? Am I supposed to start a statin on him? He's less than 130, so it's in the normal range. It's not red on Epic. Like, that's pretty good, right? But he's a 59-year-old African American male. He's a former smoker with a little bit of hypertension, no diabetes. Like, what do I do with this? And then I also asked the question, like, what would I do if I just changed it to a white woman instead of an African American man? So I guess for the first, I just want to do a brief review of like statin management. I basically, in preparation for this talk, just tried to review what we're supposed to do. So this case right here would be primary prevention of ASCVD because he hasn't had an atherosclerotic event yet. And basically, if you watched online MedEd, you remember that there's 4 indications for starting a statin. Basically, if they have clinical ASCVD, if they have hypercholesterolemia greater than 190, or if they have an LDL kind of in the mid-range, 70 to 180, age 40 to 75, and diabetes or a calculated risk score. The problem is, I think I kind of remember learning this, but it's different when you see it in real life compared to when you're just trying to remember this factoid right here. So I looked at it again and I realized, okay, so this guy fits in this category. He has an LDL between 70 and 189, his age is 40 to 75, and we can calculate his risk score. So if you go online, you can input all his lab values, and you'll get that he has a 15.5% ASCVD risk score. And then I was just curious, so I changed it to a white woman, just changing 2 variables. I left everything else the same. And I was kind of shocked to see how big of a difference the ASCVD risk score was. It was only 4.9% in the white woman. Then you can take a look at the 2018 cholesterol guidelines, and this is like a very busy picture, but it's actually very useful. But I'll just focus your attention to right here. So our patient, the African American man, falls into this intermediate risk category. And this category recommends initiating a moderate intensity statin to reduce LDL. And so that's kind of what I did. I responded to I made a result note, and I was like, maybe we should consider a moderate or high intensity statin. Interestingly though, if it was the white woman, she would have no recommendation for getting a statin, just based on her ethnicity and her gender, altering her ASCVD risk score by that much. Another thing that I thought was useful, just to go over quickly, is I learned what the expected decrease in LDL after initiating a statin was. So if you initiate a high intensity statin, you should expect a greater than 50% drop in the LDL. Moderate intensity would be 30 to 50%, and low intensity would be less than 30%. And then when should you switch someone off of a high intensity to a moderate intensity statin? So some indications in general would be age greater than 75, liver or renal disease, or statin intolerance. All right, and then going back to the first example, so this would be considered secondary prevention of ASCVD because he's already had a significant cardiovascular event. So again, I think when we watched Dustin Williams from Online MedEd, he told us when to start a statin, but didn't really tell us what to do afterwards. And I think the reason is maybe he created those Online MedEd videos before 2018 cholesterol guidelines came out, because in 2013, the use of LDL-C thresholds was not supported, but in 2018, there was a little bit more evidence for LDL-C thresholds. And as stated, in secondary prevention, you should target LDL-C of less than 70, and if they're not there, you would add ezetimibe, and if it's still not there, you would then add a PCSK9 inhibitor. So this is the picture that the guidelines gives you. And so for this guy, I basically recommended he should have a target of less than 70, so we could consider adding ezetimibe for him. So I just thought this was like an interesting review because I kept getting these lipid panel results and didn't really know what to do with them. So again, here's the indications for starting a statin, and you can use this detailed flow chart from ACC-AHA to have a better detailed indication for starting statin. Reasons to switch to moderate intensity statin are here. Expected decrease in LDL after a high intensity statin is greater than 50%. Target LDL in patients with ASCVD is less than 70. You should use ezetimibe, then a PCSK inhibitor if they're already on a max statin dose. And from what I could tell, the target LDL in patients for primary prevention would be less than 100. All right, so now we're finally going to get into the context and background for the Jupiter trial. So basically, in 1961, the Framingham study group showed that hyperlipidemia was a risk factor for CAD. This is the first time it was shown. And after that, we had a couple of studies that showed, okay, cholestyramine and gemfibrozil, they help a little bit, but there was no mortality benefit. In 1987, the first statin was approved. It was lovastatin, and I thought it was interesting. It was actually derived from aspergillus and Pleurotus astriatus, or the oyster mushroom, which were found to have a powerful inhibitory effect on HMG-CoA reductase. And then in 1994, we had this landmark study, the 4S trial, also known as the Scandinavian Simvastatin Survival Study. It's a bit of a tongue twister. But this study showed that simvastatin reduced all-cause mortality in patients with prior MI or angina and hyperlipidemia. And so this study is basically why we're always like, statins actually reduce mortality in patients with high cholesterol, okay? And these other drugs up here can be helpful, but don't. And then we had a whole slew of other studies that came out after that, which continued to show that statins reduced mortality. And in a little bit after that, we had some trials that showed that high dose or high intensity statins were better than moderate intensity statins for people with recent ACS or CAD. And then more recently, we've had some trials looking at ezetimibe and PCSK9 inhibitors. And from what I could gather, apparently people were very excited when ezetimibe came out. But then they had this enhanced 2008 trial, which showed it decreased LDL and CRP, but did not reduce progression of atherosclerosis. So that was a very, very disappointing result. And that's why it wasn't included in the 2013 guidelines. But then this Improve It trial came out in 2015. Ezetimibe and a moderate intensity statin did reduce cardiovascular mortality, but not all-cause mortality. So then in the 2018 guidelines, they included ezetimibe in the algorithm again. So I just organized these results a little bit based on whether they were looking at secondary prevention. This study right here was kind of mixed primary and secondary prevention, and this study was looking at primary prevention. And the authors of the Jupiter trial basically said this: half of all vascular events occur in patients with normal or low levels of LDL cholesterol. And if you look at this WOSCOPS study for primary prevention, they were looking at people with cholesterol or LDL greater than 174. So what Jupiter was kind of asking is, what if we have somebody with LDL less than 130? Like if they have a LDL in that range, is there any indication for starting a statin for them? So that brings us back to, can CRP be used as a marker for initiating a statin in CVD, particularly in patients with more normal LDL levels? And then we go back to the PICO question that they had. So Jupiter trial, first thing to look at is, who are they sponsored by? It's important to look at their funding sources. So the Jupiter trial was sponsored by AstraZeneca, and they are actually the manufacturers of Crestor, or Rosuvastatin. So already, looks a little bit sketchy, right? But add on top of that, 9 out of 14 authors also had financial ties to the sponsor. Okay, not the greatest start for the study, but it's in the New England Journal of Medicine, right? So it's got to be great. And this is the lead author, Dr. Paul Ridker. He's like a really well-established guy. He's got his own Wikipedia page, like publishes a ton of big name articles, I guess. So he actually owns the patent for high sensitivity CRP. So if there's anybody who would benefit from a study showing that high sensitivity CRP was useful and should be like massively prescribed to everybody to get a high sensitivity CRP, it would be him. Okay, so I think there's a lot of money involved in this study, and I think if there's sorry, did a repeat. And if there's any study that could be a good example of a possibly very strong funding bias, it's probably this one. So moving on, let's look at the inclusion criteria for the Jupiter trial. So patients were recruited from 2003 to 2006. They were eligible if they were men over 60 or women greater than the age of 60, or sorry, men over 50 and women over 60. If they had an LDL of less than 130 and a high sensitivity CRP of greater than 2. So they screened 90,000 patients and ended up randomizing 17,800 of them. 72,000 were excluded, and the main reasons, there was a whole list of reasons, but the main reasons were a prior history of cardiovascular disease, again, because we're looking at primary prevention, so if they had prior CV disease, then that would be secondary prevention. Triglycerides greater than 500, prior use of lipid-lowering meds, or diabetes. And then the patients that underwent randomization, they split half and half, one into a Rosuvastatin 20 milligrams daily group and one into a placebo group. So in terms of the study design, basically they had this 4-week run-in period where they gave everybody placebo, and then if the patients took more than 80% of their pills, then they were considered eligible for the study because they wanted to make sure their patients were adherent to the medication. Then they assessed them at 13 weeks and then followed up every 6 months after that. And so the trial was actually stopped early in 2008 when Rosuvastatin was shown to have vastly superior cardiovascular outcomes compared to placebo. And the median follow-up was 1.9 years. So one thing we want to do when we're looking at these studies is always look at the baseline characteristics between the two groups just to make sure randomization occurred successfully. And if you look at the Rosuvastatin group and the placebo group, you can see that the age is the same, the proportion of females was pretty much the same, and the racial demographics were about the same. So the study actually says we consider this a highly diverse group of patients, and I would just leave it up to you guys to ponder whether you think this is a highly diverse group of patients or not. And then all these other measures, BMI, blood pressure, rate of smoking, are all the same. So you can see that the randomization was successful. CRP, baseline LDL, all of this stuff was pretty much identical between the two groups. Then they took a look at if their treatment was working. So they looked at the rosuvastatin group and the placebo group at 12 months and checked if their CRP went down. So in the rosuvastatin group, you could see the CRP was 2.2 versus 3.5 in the placebo. The LDL was also lower in the rosuvastatin group, which is as expected. HDL was about the same, and triglycerides were a little bit lower as well. All right, so now we're looking at the endpoints. Okay, so there's these were all their secondary endpoints. So a myocardial infarction, stroke, unstable angina requiring hospitalization, arterial revascularization procedure, or cardiovascular death. And so what they did is they combined all of these into one primary endpoint and took a look at how many of these patients reached this primary endpoint. And in the rosuvastatin group, 142 patients met the primary endpoint, and in the placebo group, 251 did. So this represented a hazard ratio of 0.56 with a very significant p-value. And then the program coordinators wanted us to calculate a number needed to treat for you guys. So number needed to treat is 1 over the absolute risk reduction. So you basically take the control event rate versus the experimental event rate. And the calculation would be 1 divided by 251 for the placebo over 8,900 patients minus 142 over 8,900 patients. So the number needed to treat is 82. So that brings us back to step 1 a little bit. But the study authors noted that over 5 years, if you use their Kaplan-Meier curves or whatever, you could calculate that the number needed to treat would have been 25. So that's pretty good, right? So usually I just like to have this graphic here because I think it's a clear depiction. But here's actually their data that they presented in the New England Journal of Medicine article. And I just wanted you to take a look and tell me, basically try and figure out how many events of fatal MI were there. So I give you like 5 seconds to look at that. So they reported non-fatal MI, any MI, but they didn't report fatal MI. And I think this kind of shows how they were kind of potentially manipulating the data a little bit. So if you do any MI minus non-fatal MI, you get 9. Basically, they had 9 fatal MIs in the rosuvastatin group. But if you look at the placebo group, 68 minus 62, they had 6 fatal MIs in the placebo group. So they actually had less fatal MIs in the placebo group compared to the rosuvastatin group. But they kind of hid that by, giving you some weird numbers here. I think, the way they presented it, it's like, if you just directly compare 22 non-fatal MI to 62 of placebo, oh wow, like rosuvastatin is much, much better, right? But the way they presented it seems a little biased, is basically my point. Here's just some graphs of their event rates, and you can see that rosuvastatin basically was better than placebo in all of these metrics. And then they do a subgroup analysis. So in all these studies, they like to check if there is a treatment effect difference between different subgroups. For example, did males or females respond differently, or did younger people or older people respond differently to the treatment? And so you look at the p-values, and you'll find that there is no significant treatment difference between the different subgroups. And then finally, we look at they monitor for adverse events. So any adverse events, they found no significant difference between rosuvastatin and placebo. There wasn't an increase in myopathy, which I thought was a little surprising. No increase in newly diagnosed cancer. No difference in hepatic disorder. The level of ALT was pretty much the same between both groups. Now, one significant difference that they did notice was that the A1C for the patients in the rosuvastatin group was higher. It was 5.9% versus 5.8% in the placebo group. But the p-value was 0.001, so it was actually very significant. Although it's only a 0.1% change in A1C, so I don't know what to think of that. But they also did notice an increased rate of newly diagnosed diabetes in the rosuvastatin group compared to the placebo group. And again, that was significant. So going on to the discussion, there's pros and cons. Basically, the main pro was if we look at patients with CRP, we can start them on a statin and significantly reduce the primary endpoint. There's a 44% reduced chance of them having the primary outcome. And the main con that they reported was there was a 25% increase in new diabetes, but the number needed to harm was 165. Okay, so now I'm supposed to facilitate a discussion. So based on these results, now we want to look at, what do you think about this study? Like, what's the validity of this study? Is it generalizable? Do you think the study design was good? What opinions do you guys have about the study, and do you think you would incorporate high sensitivity CRP in your practice? So if anybody has any opinions.
Yeah, I thought that was great. Good job, man. Very interesting stuff, and like good job like picking out the small like nuances, particularly the MI stuff. I didn't really see that the first time around. When I read the study, like the thing that stuck out to me the most was like the inclusion criteria to me seemed pretty strict. Like no diabetes is that excludes a lot of people, and then CRP is also like one of those non-specific markers too, right? So if you have some sort of inflammatory syndrome chronically, like that would cloud whether or not CRP can be used in this case, I think. So I think in terms of like generalizability, it seems like it's not super generalizable, this particular study. You need someone who otherwise has like no significant medical history at all, and then they just incidentally have a high CRP, and maybe this might apply.
Yeah, those are really good points. And then, yeah, what do you think about the demographics of the study? I guess it's a bit of a leading question. But one of the things was, first of all, I don't know if 20% having like 20% of Black and Hispanic is considered like a highly diverse study if it's 80% white. But the other thing that was noted is that there were no Asians in the study. So I'm going to go to this. This study was highly controversial when it came out. So it says, although Ridker state that by design the study population was diverse, no Asian countries are included. It would appear that there may have been a conscious choice to exclude people of Asian descent from Jupiter. And this is from Georgetown, so this is Dr. Bergman from Dr. Crackler's alma mater laying down the law. But yeah, I think there was a lot of other problems. Oh yeah, what do you guys think about the trial stopping early?
Sunny's nodding.
Oh, Sunny's nodding.
You want to say?
Sure. If they tracked it longer, there could have been, even more diabetes found in these patients, and it could be even more harmful than what is stated.
Right. Yeah, that's exactly it. So the trial was stopped early, and when trials are stopped early, this tends to overestimate the treatment effect and underestimate adverse events, so like new onset diabetes. Of course, we discussed the strong funding bias and the apparent obfuscation of data. So there is this article, I'm just going to go to the conclusion, I guess, but there is this article in 2010 that basically like just destroyed the study and like really tried to like talk about all the negative points about this study. So one of the things is the study was ended early. And everybody thinks that the trial should have been going on further, especially because if you look at this graph from the study, the rosuvastatin and the placebo groups seem to be converging towards the end. And then they're like, oh, let's just stop the study. Normally you would expect these to be getting bigger and bigger, and then you're saying, okay, there's a safety issue here if we don't continue, if we don't stop the trial. But it looked like these were kind of getting back to the same point. So when people started bringing up this point, the authors actually tried to, make some rebuttals to this, and they actually changed their graph, and they removed this part where it looked like they were converging. So I think they like purposely are trying to like change the data a little bit to make it look better than it was, right? Now it looks like they're not converging. Another thing is if you look at all the secondary endpoints, or the components of the primary endpoint, these two right here, hospitalization from unstable angina and need for arterial revascularization, those are not complications by themselves. Those are like medical decisions. And if you remove it's not really like a hard data point. It's something that can be manipulated. Whereas these ones, MI, stroke, cardiovascular death, these cannot be manipulated as easily. So if you take a look at this and make this the primary endpoint, just these hard data points, you can see that rosuvastatin had 31 events and placebo had 37 events, which was not significant. And if you just look at these two over here, rosuvastatin and placebo both only had 12 events. So there was no difference between the two groups. So they kind of were choosing data points that would help get them to get the result they wanted. And then there was 3 prior really strong RCTs that showed rosuvastatin did not reduce coronary heart disease. And this article didn't address at all why suddenly they did a study that showed that it did. They didn't provide any explanation for that. So yeah, basically, moving forward, you can use the 2018 cholesterol guidelines, and you can see, this is like a risk enhancer. You can look at the CRP, but I think in general, it's not going to be standard practice to be using high sensitivity CRP in these patients. And here is a poll in the New England Journal of Medicine. Do you think this should change our practice? And it was very controversial and very mixed. In conclusion, so I think Jupiter basically reminds us that we should always take a very critical eye to these studies, especially when they seem to have very promising results. And you had to be very careful, just like the 7 countries study that I brought up earlier. You had to be very careful of people presenting the results in a certain way that leads to their conclusion, but it could have had some manipulation in there, which resulted in them kind of misleading you when you're reading the article. All right.
All right, great job.